As many of you know, and as we have just heard very poignantly, family physicians are under a great deal of stress here in Saskatchewan and across the country. The challenges in family medicine are real, and the SMA has been working to find solutions for a while now. In fact, a couple of years ago, the SMA, together with the Ministry of Health and the Saskatchewan Health Authority, created the Primary Care Compensation Working Group. At the 2022 Fall RA, delegates heard and discussed the working group's preliminary findings. Today, we will hear about the group's final recommendations and next steps. So please help me welcome to the stage SMA President Dr. John Jeffrey and SMA Board Member Dr. Carla Holanati, along with some of the members of this working group. Come on up.
Thank you, Kishore. So I believe that Carla and I are going to sort of tag team this introduction, and I'm going to have Carla start. Oh, I'm told I have to start with the slides. Okay, so first slide. So as Kishore already mentioned, as part of the previous negotiations, there was agreement to have a joint working group with the government to have a primary care compensation working group looking at ways for innovative change and a new approach to improving things for our family physicians here in the province. So as you can see on the slide, which I can't easily see, this was established. We have a working group we're going to introduce in just a few seconds. Let's go to the next slide. That slide sort of tells us about it. And here's our group. Not everybody, I believe, is here today, but many are. And we're going to have them come up in a few minutes. And we have, as mentioned, members of that team were both from the SMA, the Ministry of Health, as well as SHA. Next slide. And, you know, previously I've said this, that the bedrock, the foundation of healthcare system are our family physicians. Many of you have heard some of the stresses in that we have approximately 200,000 people in this province who don't have a regular family physician. And maybe they get some care going to walk-in clinics or urgent care centers or the ER, but that's not longitudinal care. It's not ideal care by any means. And we need that foundation to help care for our patients and to have a system that works for all. You know, Dr. Epp was telling me last night how she keeps getting numerous referrals directly from the ER of patients with complicated surgical issues, and they don't have a family doc, right? And that's not a good healthcare system. We need everybody to have a family doctor, and we all want and deserve a good healthcare system. Let's go to the next slide.
So we know that our patients are frustrated. They're not able to access their own family physician in a timely way. They've lost their family physician to retirement or moved to other types of practice in hospital or in different sorts of clinical settings. And our population continues to get older and more complicated, and we see more and more chronic diseases. And those people are getting less access to the healthcare that they need. They're waiting too long to get the care that they need. They're decompensating in community, and like what we heard Dr. Leese say, they're ending up in hospital sicker than they would have been and staying for longer and having trouble being discharged from hospital because there's no one to care for them. And when we do see those people, we need to spend more time with them. So instead of, seeing a handful of patients that maybe just have hypertension and we can care for that pretty simply, they've got diabetes and they've got heart failure and they've got COPD and they're depressed, plus, and those just aren't things that can be handled in a 10-minute appointment. Next slide, please. In addition to our patients suffering, our family physicians are suffering and they're struggling. We know that 65% of our respondents reported their mental health was worsened, and those within their first 10 years of practice were worse than that average. 74% expressed that medical practice was less satisfying than it had been in the past, and 62% said that they were likely to reduce their clinical work hours in the next 2 years. So if we are already starting from a place where we do not have enough people, thinking about losing more of those people and losing more of those clinical hours that are accessed for patients and critical for keeping patients well should worry us all. So if you look at the sort of domino effect of what happens when we lose even one family doctor, so if you're looking at lots of the people in this room who are maybe getting near the end of their career and considering leaving practice or retiring, they might have 1,500 to 2,000 patients that are attached to them right now and rely on them. But if there's nobody to take over for them when they leave, every single one of those doctors who leaves without a replacement now leaves 1,500 or 2,000 patients behind. And those patients have nobody. So what do you do if you don't have a family doctor and you need care? You go to the emergency room because that's a place that's always open. We know that there are doctors there and you can get help. But as we heard from Dr. Toma, there's no space there. The people that are waiting to be admitted are taking up all of the beds, and they're waiting for hours and hours in hallways or with paramedics because that's the only place that they can access healthcare. And that, if I get a little choked up, that hurts my feelings, that breaks my heart every time I think about it. We heard also from Dr. Toma, ambulance delays, poor emergency response times, days where in a city as big as Saskatoon, there are 0 ambulances available because they are all waiting in back hallways, taking care of patients who are too sick to be left unattended in an emergency room waiting room. So then, like we heard from Dr. Lees, these patients are in hospital. They take care of them, they stabilize them, they need to get back out to community, but they're still sick. So what do we do with them? Nothing. There's nobody there. There's nobody that can take care of these folks. So they get discharged to community with complex care needs. They're stable enough to not need hospital, but not stable enough to not need care. And they just have to do their best by themselves in the community. And then they get sicker. And so what happens? They still got nobody. They go back to the emergency room, and we repeat over and over and over again. And our already broken system breaks more, and our already burnt out physicians burn out more, and our already stressed and struggling patients suffer. Next slide, please. So physician compensation is a barrier. We did do our membership survey in 2022, and that's not a typo, 0% of responding family physicians in their first 10 years of practice told us that they saw fee-for-service as more desirable, especially after the COVID-19 experience. 0% of our new doctors are telling us that they want to work in a fee-for-service environment. 74% of our family physicians that were paid fee-for-service reported feeling more negatively towards it after the experience with COVID. 3/4. And this translates into our new graduates choosing not to stay. So they are choosing not to practice family medicine. Maybe they're looking at doing hospitalist care. Maybe they're looking at doing pre-screening and other types of specialty care. But some of them are leaving the province entirely. And that means that we continue to not have those new people coming in to replace the people that are leaving. And we've seen this trend not just here in Saskatchewan, but nationally. And it's an ever-dwindling population of family doctors with no reinforcements coming, no hope on the horizon. The doctors that want to leave have nobody that they can look to start making plans to transfer those patients. And then I think this is where Tahira, others are coming up, or is this me still? Still me, okay.
Still you, me.
Or John.
I think it's me.
Okay.
So there's a crisis in family medicine. We need to emphasize the urgency of the situation, and the time is now for reform. We need to change how we address things so we can have a healthcare system that truly functions in the 21st century. You heard earlier that, fee-for-service, it was the last big change that occurred after the doctor's strike of 1962. So we are, 51 years ago we designed the system we have now, and it worked great for a long time. But it's not necessarily the best approach here in the 21st century. So we need to stress there is urgency around having a different system, a more innovative way to compensate physicians and to keep the system running better. We heard earlier from a patient family representative how they're concerned. You've heard earlier from people like Dr. Toma how the ER is blocked. We have to change our approach. Doing more of the same is not necessarily going to fix things. So there is, I think, a very strong sense of urgency around this. Next slide. I think we have one more slide. Yeah. So how can we provide good longitudinal care for patients in the community? And the idea is to have a team-based approach where you have the patient at the center, you have the family physician as the quarterback of the team with all kinds of additional supports around that. And we've said this before, if the Rough Riders just had a great quarterback and everybody else was absent, you'd never win a game, right? We need to have everybody taking care of that patient. And there has to be a model that is fair and compensates people to have that kind of team-based approach. So without further ado, I'm going to ask our primary care compensation working group folks to come on up here to the stage, and they're going to tell you a lot more. Come on up.
Give them a round of applause. They've been working really, really, really hard.
Is that on? Yes, okay. My name is Ginger Ruddy. I'm a family doc here in Saskatoon. Thanks very much for your attention. So if we can go to the next slide, please. As you heard from the physicians who were presenting to the ministers with their questions, we need stabilization first. We're in this urgent place where unless we figure out a way to make sure that physicians are paid for the work that they do, and a much larger proportion of the work that they do than they currently are, we're not going to have what we want, which is family physicians and specialists working in concert seamlessly to optimize the care for the patients. We would all love a world in which our resources were aligned and the infrastructure we need to work those resources were funded. And so that care keeps improving, so that patients get the benefits of it, we do have to embed continuous improvement, which means research and cycles of testing things and seeing how they work. And we can support one another so that that can be part of our work and not feel like something extra. And then, of course, the patient-centered integrated team with physician leadership close to the patient's home and well supported is the one that results in the best outcomes for patients, the best patient satisfaction, and the best physician satisfaction. As an added benefit, it lowers costs by reducing those pressures on the ER and inpatient settings that we know need to happen. Next slide. Thank you. So this change is transformational, which means, as you heard, the complete change is not going to occur in this very short timeline in which we need stabilization. But if we do it right, we're going to get the kind of care we want. Next slide, please. So happily, we don't have to invent the wheel on this one. The patient's medical home model, with this cartoon that was put out by the College of Family Physicians of Canada in 2019, has been shown, when fully implemented, to achieve the kinds of things we're talking about. And it involves great evidence that we can actually get the kind of care we want for patients. Next slide. So we've been hearing about access and the need to improve it. And we've had colleagues talk about the fact that while urgent care will give people access to episodic things for things like lacerations, it won't create the kind of care that we know that patients need and benefit from. And if we implement the patient's medical home, we can reduce that strain on emergency rooms and hospitalizations pretty dramatically. And our patients with chronic disease will disproportionately benefit. And we know that those are the patients who have the highest use of our services. Finally, we can go from that number around 40%, which is current in Saskatchewan, to closer to 80% of patients being able to get same-day appointments. Next slide. Okay, I'm going to hand it off now.
Thank you. Good morning. I'm Melissa Kimmins, Executive Director of the Connected Care Services branch with the ministry and a member of the Primary Care Compensation Working Group. On this slide, you see a representation of the ideal health ecosystem. And I think the story that I want to tell here is really the recent history of our primary care strategy, which is really built upon this as well. So 2009, we had the patient first review. 2012, we had the primary healthcare framework developed. Fast forward to 2017, we had the Provincial Health Authority, the Saskatchewan Health Authority, created. And in 2017 also, we had the Connected Care Strategy developed, which really, it aligns and supports the patient's medical home. In 2018, we had health networks begin to form across the province. You could sort of back up the clock a little bit. I know that it started in pockets prior to the creation of the SHA, but really in 2018 is when those boundaries were formed across the province, and that process of maturation really started. The purpose, of course, for these networks is to provide a network of healthcare professionals of all types who work collaboratively for the patients, with family leadership right there at the center. And so sort of the segue to the next slide, what do all of these initiatives have in common? It's really an emphasis on the fact that the patient's medical home is at the center of the health network and of care in general. And this patient's medical home, which is of course family-led or family physician-led practice, right there as near to home as possible, it really helps achieve the quadruple aim of better outcomes at a lower cost and providing improved experience both for patients and providers. Passing it on.
Hi, so I'm Dr. Craig Canton. I'm a fee-for-service family physician out of Prince Albert. So as part of the working group, we first started with an analysis, and our analysis was that it's not working. Anybody who works, I guess, has a fairly good idea of some of the reasons why things aren't working. So for instance, in a fee-for-service model, there's no real compensation for additional work with complex patients. Fee-for-service is very good at creating access and volumes, but not looking after patients who may be complicated. Also, there's disincentive in fee-for-service for team-based care. If you delegate something to somebody else, you don't get paid. So nobody wants to do that. In fee-for-service, there's also no time compensated when you're doing administrative tasks. That's all on your own. The current non-fee-for-service models, contract and salaries, they do some things really well. They're paying for time. Complex care is not necessarily disincentivized. We have noted that in Saskatchewan there's a significant lack in accountabilities in a lot of the models. They're maybe written in but not necessarily enforced. And patient access can sometimes suffer, as well as obviously outcomes if patients can't access the care. Next slide, please. So looking at all the different models that are available, we came up with a recommendation. So our recommendation is over the next 10 years, build a Saskatchewan-designed blended capitation compensation model for physicians. We realize that nobody wants to hear that 10 years, but we'll get into why it's there. But that's our end goal. That's where we want to be. Blended capitation, we're going to need supports for physicians. We're going to need infrastructure. We're going to need ability to collect data. We would like to have this model work within the patient's medical home and the connected care strategy. Factors that this type of compensation model will address will be the patient access, the long-term attachment, team-based care, mutual accountabilities, and that's with the physician, the patient, payers, as well as the provision of complex care and compensation for indirect patient care. Next slide, please. So what is blended capitation? Capitation sometimes has a negative connotation for some people who've come into contact with forms of capitation in the past, but I think that's not what we're talking about here. In a blended capitation system, physicians are self-employed, they can work in groups, and they can own and operate clinics. They can choose to work more, or they can choose to work less. In a blended capitation model, people are paid a dollar amount for each patient under their care, and that dollar amount varies based on the complexity of the patient, and that's one of the areas that we will have to refine. Areas for complexity could be age, sex, and so age and sex, as well as medical conditions that they may have. Physicians can then earn additional monies for accepting additional patients, rostering more people, having additional responsibilities, and other services. You'll start to hear terms of in and out of basket. So within the capitation, there will be services that are covered, and there will also be services that are not covered, and one can bill for those services. One can then also do additional work outside your capitated services if one so chooses. So very importantly for this model to work, you need accurate data and you need timely data regarding the patients and their complexity and uses of services. We need measures and mutual accountabilities for patients, providers, and funders. Obviously, providers need to know what they're expected to do, but patients will also need to be educated, because in a blended capitation system, the expectation is that the patient gets their care from their rostered physician for a number of reasons. Okay. Why do we want blended capitation? I think you'll notice if anybody's been paying attention to any of the news reports of new ways of paying people around the country, pretty much all of them have landed on this sort of blended capitation model that they're aiming for. Why? Because it has a strong focus on patients, using patient data to inform compensation, and making the relationship between the physician and the patient central to its working. Contracts are currently paying for time spent with a patient, but capitation pays for providing continuous care to the patient. And it adjusts the payment based on that particular patient's complexity. Okay. It incentivizes the improvement of access and care. It incentivizes rostering of more patients. Doctors can choose to work more if they want to earn more and look after more people. But in this type of a system, the doctor isn't paid for sitting in front of the patient. Doctor has the ability to work in a team, work more effectively, potentially look after more people in an effective manner, using other team members that possibly at the moment aren't well utilized. This will take time to build. We need to build the infrastructure in order to collect patient data. We need tools, we need resources. We need a sea change in terms of the way we do things. Doctors will have to get used to a new way of providing care compared to how they have done it in the past. It's a cultural shift in how we will providing care to patients. Not only doctors will need to learn a new way of doing things, but patients will also need to learn a new way of doing things. The public, well, we all need to be prepared and to be made ready for this. And this is where we want to end up. And I think Kirsty's going to talk a little bit about ways to get there.
This is where I wish I wore my heels today, because everyone's taller than me. So I'm Kirsty Sanderson, fee-for-service physician in Moose Jaw. I'm part of this excellent group we've been working with for the last couple of years. So, oh my goodness, 10 years. Everybody went, seriously? I need some help now. We can't wait. And we know that, and obviously we've talked about that this morning with the minister. Next slide. So we also developed some sort of recommendations, knowing that obviously this blended capitation model needs to be prepared properly. We want it Saskatchewan designed. We want it based on the right data. And of course, all that Craig's talked about is going to take some time. How do we help now? How do we also transition? Because going from fee-for-service straight to blended capitation is no easy feat. I mean, that would be, you couldn't do that overnight. But is there a way that we can actually help move that along by changing some of the ways we pay docs now to make it a smoother process into blended capitation? So one of our recommendations, obviously, is to stabilize family medicine now prior to this full implementation, and develop some pathways, both fee-for-service and non-fee-for-service, who choose to do so, to help them transition towards this model. Next slide, please. So our proposed actions were that we would need a working group a physician working group is actually, preparing a transitional pay model plan for fee-for-service family physicians. And our aim is to submit this detailed compensation plan by end of June to the Ministry of Health. And then, of course, we would have to start working on some non-fee-for-service pathways also. And we would want to plan to identify that project and team and group by June 2023 as well. Next slide, please. Fee-for-service pathway goals. So these are pathways to blended cap, would obviously to start immediately improving access for patients to family physicians, hopefully help retain family physicians, those who are thinking of moving or not staying because of the reasons we've all talked about this morning, attract the next generation, of course, the graduates as well to stay, and create the conditions and build those teams ready for blended cap. Next slide, please. We do want to build on some lessons, of course. We're not trying to reinvent the wheel. From BC, Ontario, and Alberta, and Newfoundland and Labrador also recently announced a blended cap-like model. We do want to offer options to all family physicians, all applicable family physicians, both individuals, small groups, and large groups. So we want to make it work for everyone. We understand that one size doesn't necessarily always fit all, but you can certainly develop a model that will work for everyone by having various options. The plan is to make sure it is inclusive. And this pathway would certainly start compensating for volume, of course, where we do want patient access, but the unpaid work, the indirect care, and the administrative work and burden that we all suffer from. Also the teamwork that and learning, data collection, using the EMR, leadership, health network meetings, and quality improvement, all a very important part of establishing a good team-based care system. But we want that to be compensated for. Accountabilities, patient attachment and complexity needs to be compensated for. The current fee-for-service model certainly doesn't recognize, the 85-year-old with 6 problems that you have to try and deal with in 10 minutes. After hours and on call, of course, but also those of us who run businesses and also involved in that side of things. We need some help with clinic staff support, non-physician providers, and other clinic enhancements that might make that patient experience a lot better. I'll hand over to Alyssa.
Groves is my spotter there. The next recommendation that we'll talk about then is the importance of shared governance. And so we know that moving forward, we have to collaborate. And so this will be an ongoing, collaborative effort between the SMA, the Ministry of Health, and the SHA as well. And I mean, that's the group that has worked together to bring us to this point too. And then in terms of the work ahead, the proposed action, of course, is, read the slide here, determine shared governance and operational team prior to June 2023. So we're on the clock for that one certainly as well. Thanks.
So 2 years ago, I got into this, and I'm so ignorant of how the system works. I thought we're all going to be on the same page. We're just going to kind of look at the goal and move towards that goal. And it doesn't work like that. But the announcement from Ministry today is huge for the work we've been doing. Up until last week, I didn't even know if it was going to happen. Because transformational change and aspirational, innovative work requires a whole lot of people to all be on the same page at the same time under the right conditions. And that doesn't come along very often. And in Saskatchewan, it really came along 51 years ago. Like John said, we've talked about 1962 a few times today. And, this is a potentially seminal moment. Like I said, I'm still hedging my bets. But we've seen the important kind of decision makers in our system come together over the last 2 years, and today is the first day where we've all said, okay, we have a common goal, we have a place to look towards, we have an ideal state, and we can all start the work of doing that. So again, the news today was really great, but honestly, this is the start of the start, which means there is a lot of work to do, and hopefully in a very short period of time. I think we've all been mentally preparing for a lot of work ahead. But again, to see everyone kind of align is really, really hopeful, and I do think the potential for transformational change, not just in primary care, but in the health system and how we deliver healthcare to patients and include patients in our health system, the potential here is huge. So moving away from these ideas of kind of siloed decision-making, siloed care is extremely important. And I think we're there. I think there's an appetite for this. And again, the environment is right. The SHA has its feet under it. The SMA is leading. We've heard our specialist colleagues. John Jeffrey has been a passionate advocate for primary care. He's not a primary care physician. So our system is ready for this. And so I think we're all ready to move it forward. I only had 3 slides, so I got to talk a little bit. I think that's all I've got for my. Oh yeah. We have seen today, and we see in this room today, how important physician leadership is in moving the needle forward when it comes to health system transformation. And I think the incredible responsibility that comes with this is gonna come a lot from us. Obviously we're going to work with our health system partners, but when physicians lead this work, we know it can be done well. And I think, and that comes at high levels in terms of decision making, but it also comes at the level of individual clinics and individual leaders developing a patient medical home model that can serve the needs of patients and trickle down across the entire system. Thanks.
Thank you so much, Sean. So to look a little bit deeper into these recommendations, one of the things that you heard, and you heard several of our questioners of the minister ask today, was how do we continue the work? How do we keep moving forward and not let this just stagnate as a lovely plan that slowly grows mold? So we do need to develop a change management strategy, and we need to get engagement from all of the stakeholders. Of course, physicians being amongst the most important, and both primary care physicians and specialists have to be involved so that we can all try and get the system to look more like we'd like it to. And then we need engagement with our patients, the people for whom we're doing all of this, to understand where their care is working, where it isn't working, and where we need to make it better. And then the end of that sentence is the key one. We need resources for this to work. This isn't going to be cost neutral at the start, and that's a part that's challenging. However, we have the evidence that if we do it right, the savings on the downstream end make the investment on upstream worthwhile. So Our proposed actions for the time being include these targeted meetings with different project partners to continue the work and moving it forward. They also involve a communication strategy to talk to all of you, all of the people you represent, as well as the people of this province, because as we know, what motivates government most strongly is what voters want. And I think if patients understand what's on the table here, they're going to start to clamor for it and say, this is the kind of care that I want. I want my physician to be better supported so they can take better care of me. And so there are a bunch of different activities outlined there that are going to help with communicating these recommendations more broadly. Next slide, please. And so system transformation, as we indicated, complex, time-consuming, but absolutely worthwhile. If you think of 1962, obviously that wasn't easy, but we got somewhere better than we'd ever been before, and we believe that this transformation can be as significant in terms of changing the way that we offer care and creating the kind of system that we'd all like to work in. It involves some of these sort of more logistical features, which aren't as much fun to think about, which makes sense. If we have the entire ICD-10 or ICD-11 instead of a fraction of ICD-9, we'll be in a position to actually document what we provide each visit more completely and more accurately. And that will let us know the complexity of each patient and then figure out how do we guide the care of that patient. It'll also help determine how big a person's panel should be, because if your patients are all 25-year-old healthy people, you're going to have a different patient load than someone who has a lot of 75-year-olds with multiple chronic comorbidities. And then other elements will be things like further data infrastructure, interoperability between our different systems, which currently don't chat very well with one another, and the resources to do the kind of quality improvement that we'd all love to do, but mostly end up doing off the sides of our desk right now because that work is uncompensated. And so by the end of this next month, we hope to have objectives for each of these streams of work developed. And if you find yourself getting fired up about any of it, I want to encourage you to think about whether it's something you'd like to be involved with.
Ready for questions?
All right, so recommendation 2E is to co-locate allied health professionals in clinics. Really then this is about identifying what are the appropriate teams to support patients and all of those providers, so based on population needs. The proposed actions here are to develop a provincial co-location strategy inclusive of all clinics, and build on lessons learned from current Ministry of Health and Saskatchewan Health Authority examples.
I think everyone's ready for the break. We are going to head to some questions for those who wish, but just quickly, our sort of timeline again. So we have the SMA President's Tour between May and June. Hopefully draft plans for implementation over the next couple of months. Submit this transitional pay sort of a model proposal by June 30th. Then usually that would go to the FP board with their intent to implement that pay model in 2023. Of course, the minister talked about a year, but we're going to obviously hold him to some tighter time frames, we hope. And then 2024, obviously, we're going to have to continue that work in healthcare transformations and ongoing forward from that. So thanks for your attention. Again, I know we've presented some of this before. For those, if it's new to you, if you have any questions, please let us know. We're going to see if there's any time for questions from the floor. Thank you.
Are there any questions from the floor? Can we come to microphone 2, please? Again, 2 minutes maximum, please.
Gotcha. Hello, Dr. Carissa Braban from Moose Jaw, Family Medicine. I'm very interested in this work, and I'm so thrilled and happy about what we all heard today, and I really commend you guys on your work. This is absolutely amazing, and it's so nice to see an actual plan laid out with steps and proposals, and like this is what we are going to do for each of these areas that needs attention. And I think my main question is, where should we look for communication in terms of where we are at in each implementation? Is it going to be the medical staff associations giving the information to their local teams? Is it going to be president's letters? Where should we look for information on where we are at each step?
So I might not be the best person to answer this, but I think, it's one of the challenges that we've had kind of through this process is actually needing to hear from people across the system. And we've kind of relied on a bit of coalition of the willing and, you know, people who are interested and engaged. But I think we have been working pretty hard with the SMA communications teams around how this will look. So I think a lot of this work is going to be led through the SMA, and also messaging through the media and things like that, because we need to get it right, and we need to get it to be clear. I think there are plans as we move forward and have solid, like it's been hard to kind of say, hey, what do you think about this without having everyone in agreement on, just moving it forward. So now that we have that, our ability to engage with physicians through the President's Tours, through SMA communications, and through SHA leadership as well, I think we've had lots of support in that regard. So it will be multimodal.
Okay.
It better be.
It better be. Thank you.
The three questions, or the three questioners who are at the microphones, those will be the three questions that we'll take before we take a break. So let's come to microphone 1, please.
Huge congratulations to the group. I'm Brady Bouchard. I'm a family physician in North Battleford. Very exciting times. Quick question around tying into the federal government's announcements and the bilateral agreements with the provinces, roughly $100 million a year to Saskatchewan over the next 10 years. Is there discussion around specific funding around the transition piece? Because family physicians will want to work in these models, of course, and hire other team members, but it'll take dollars around change management and quality improvement.
Do you want to answer that? Might be better. Sorry.
Hi, I'm Mark Caesar, SMA staff, working with this group. So no commitment yet to funding. We've certainly asked the question about how the federal government dollars are going to be spent. So to be determined, but certainly on the ministry's radar.
Microphone 2.
Thanks. Ben Lees, Chair of the IM Section, RA Delegate. So I want to echo everyone's thoughts on congratulating you on your leadership, and thank you for such a clear explanation of what's going on. I have 2 questions. That's cheating, I realize. The first question is just about how does this model take into account environmental sustainability, and how will this potentially improve the environmental footprint or the carbon footprint that medicine already makes in Saskatchewan, because that might be something to, improve, the buy-in from government to say, hey, this will actually help us reach, some carbon targets. The second thing I was going to ask is regarding quality improvement. So there's always a lot of emphasis around getting things right, and we got to do it right, and we don't want to fail. But the fact is, you will fail in a lot of ways when it's implemented, and that should be expected. The question more so to ask is, what metrics will we gather to know that we failed so that we can then address them? I think we all agree this is an awesome change, and we're all going to get behind it. But what metrics will you gather, and how will you ensure that that continuous evaluation of your program exists, and that you're reassuring the government, physicians, and patients that the changes that you're making are going to benefit them? Finally, as a specialist and as a representative of many specialists, please let us know how we can engage with this work and how we can help, because we are more than happy to do so.
Thanks. Great questions. For the second question, I think within the weeds of our recommendations, we definitely want to get the feedback and the information as we get going to see that this is working. We need the infrastructure, and obviously the data is only as good as the people feeding it in. So we absolutely would want to have a loop in the system that allows us to follow up and see that things are improving and that patient access is improving, and everything that we're hoping for comes. So yes, we're definitely, that's definitely in our sort of recommendations and our thoughts. The first question, I'm not quite sure how to answer that. That's a really great question. I think, are you asking about the way that we treat patients, how that has an effect on the environment? Can you just maybe clarify that?
Yeah, I just meant, like, for example, would this new model cut down on travel times, less carbon emissions? Would we produce less waste? Would we be able to do more virtual care and have patients, those are kind of the things that come to mind.
You answered your own question. No, like, yes, and yes. The thing about the way that capitation models are structured, you move away from this idea that you have to do something to get something, and you move towards an idea or to a concept where you have a group of patients in your practice that you're going to care for, and you do it in the way that makes the most sense. And a lot of times, driving to the clinic, even driving down to Saskatoon from La Ronge to see a specialist for sometimes 5 minutes. I'm sorry, specialists, sometimes that's what it is. It's very disruptive, it's environmentally unfriendly, but models like this allow us to focus on the work that needs to get done rather than dragging people in so that we can get paid. And again, I'm not anti-fee-for-service. I've worked in a salary model my whole career, but I try to think like a fee-for-service doctor because it's a good way of thinking about how to deliver volume and access. And so we can't throw that out. But at the same time, I honestly got into medicine to do the work. And I want to be in a compensation model that allows that to happen. And again, I think one of the side benefits of that will be that patients will be able to access our services in a lot more innovative and unique ways than they have been able to in the past.
Final question, microphone number 1.
Hi, Francisco Garcia, Urology Swift Current. So my question has to do more with the team base, which is a great model to work towards and to move towards. Where is the funding for all of those team members coming from? Is it secured? Is it hopeful or expected? Who's deciding the number of team members per the practices that you're setting up, and what team members are there, nurse practitioners versus nurses versus LPNs? And where are all those decisions actually happening? And then just maybe one step further, that, also this is a great support for those practices as they start to set up, but there is also going to be potentially some opportunities for supplementing some of the team-based care into specialty practices, particularly rurally. For example, about 15 to 18% of my current patient load is patients that I can't discharge to family doctors that don't exist anymore. And I can't see new people. And this is one of my major problems. So I've been writing prescriptions for statins and hypertension and the occasional birth control pill because they can't get it. So, that's another thing that is important. I know we want to focus on primary care reform first and foremost, but that can also be something that can be tacked on to what we're talking about.
Thank you so much, Dr. Garcia. So, in good news, lots of these resources already exist in our province and aren't necessarily optimally deployed. And so whether it's virtual or real co-location, then we have an opportunity to make sure that we take advantage of the reality, which is that the family doctor's office is a place that very easily draws patients in. So rather than them having to go somewhere separate to see the diabetic educator or separate to see the counselor, if we do it right, people will be coming to their patient's medical home, to their home clinic to get the care that they need. And many of those services will be people who are already in our networks and just aren't potentially optimally deployed so that they can actually have a full schedule each day. And you're right, you shouldn't have to be doing primary care, and I'm confident that your patients are really grateful that you're offering that. But our goal would be to do the right kind of needs assessment so that we can figure out what clinics need what supports. It's not something that's going to be top down. It's going to have to be determined by physicians and their patients and the community. And it might look really different in La Ronge than it looks in Estevan. But if we do it that way, and then we create the kind of links that we've been talking about between specialty and primary care practices, then I think we can accomplish what you're speaking to, where there are the kind of connections that result in care being done where it should be done by the person practicing at top of scope, so that, like, I'm a terrible social worker. That work should be done by a social worker, and then I can see more patients. If you don't have to do primary care, you can do more urology. Everybody wins. So if we do this correctly, it doesn't actually involve the creation or manifesting out of the clear blue sky a huge number of new folks. Yes, we still have that human resource shortage everywhere, but it isn't as desperate as it could be if we didn't redeploy what we currently have.
Thank you very much. This has been a lot of work, and this has been important work. We'd like to show you our appreciation.